Hi guys, welcome back to the channel. Today we discuss Classic 1 trial restriction of intravenous fluid in ICU patient with a septic shock.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in adult patient in ICU with a septic shock, does the restrictive approach to fluid therapy compared to the standard care result in fewer deaths at 90 days? This is a classic one, and first is also classic liberal versus restrictive fluid therapy in septic shock. Background for this study: fluid therapy in critically unwell has been widely studied across the many patient population. Higher volumes of a fluid in a patient with a sepsis and septic shock has been associated with the harm, although meta-analysis show that the quality evidence was very low. The andromeda shock trial demonstrated in those with a septic shock that by 2 hours only 25% patients were deemed to still be fluid responsive. This trial discussed in our channel in a separate video. The classic pilot study showed that the restrictive fluid strategy was feasible and showed significantly less fluid was used in the first 5 ICU days in restrictive group. This also we discussed earlier trial in our channel. You can find this classic trial video in our channel and I will put in the description box. Mortality at a 90 day was exploratory outcome and this was reduced in restrictive group, although not significantly. Design for this study: stratified parallel group open label international randomized control trial. Randomized is the 1:1 using the central web-based system, block size 6 or 8, stratified according to the site and presence or absence of metastatic or hematological malignancy. Treatment group assigned not masked by clinicians, patients and investigation. Those on data safety monitoring committee, statistician assessing the outcome and the management committee writing the abstract draft will be blinded. Receive assigned intervention from randomization until ICU discharge for maximum 90 days. If readmitted within the 90 days, then treatment assignment continue. Data collected from medical records and registers. Patient or relative contacted if further information needed. Specified groups including need for respiratory support, AKI, lactate more than 4, weight more than 76 and more than 30 ml per kg fluid administered in a 24 hours prior to randomization. Power calculation: 1554 patients needed to show 7% absolute reduction in 90-day mortality from baseline of 45%. Type 1 and Type 2 error rates 5%, 20% respectively, based on pilot study prior to the RCT systemic reviews. This trial also registered in clinical trials government in USA. Setting for this study: 31 ICU in Europe. This study was performed during the November 2018 to 2021 November. Population for this study: inclusion criteria: age must be more than 18, septic shock according to sepsis 3, suspected or confirmed infection, plasma lactate more than 2 ml or vasopressor requirement, 1 liter of fluid administered in the prior of 24 hours within a 12 hours of screening. Or exclusion criteria: septic shock more than 12 hours, life-threatening bleeding, burns more than total body surface area more than 10, known pregnancy. Total 2223 patients screened, 1554 randomized, 770 in restrictive group and 784 to standard group. Comparing the baseline characteristics of restrictive versus standard care: age 70 versus 1 versus 70, male 59 to 58. Median time from ICU admission to randomization 3. Median predicted mortality 40. Source of admission emergency department and ward. Source of infection GI, respiratory, urinary. Median highest elected 3.8 versus 3.9. Highest dose of non-adrenaline. Median volume of IV fluid in prior of 24 hours. Systemic glucocorticoid use and use of respiratory support NIV and invasive mechanical ventilation. Intervention for this group. Restrictive group, fluid could be given for severe hypoperfusion, lactate more than 4 millimole, MAP less than 50 mmHg with or without vasopressor or anotropes, mottling beyond the kneecap, urine output less than 0.1 ml per kg only within the first 2 hours post randomization. If met any of these criteria, then 250 to 500 ml bolus of crystolide could be given, followed by re-evaluation or losses, but not only correct the loss and not more. If oral enteral tube contraindicated for water or electrolyte solution, then IV fluids could be given to correct electrolyte dearrangement and ensure the 1 liter in 24 hours total intake. Fluid with a medication and nutrition count is input. Fluid for medication should be reduced to lowest possible value. Control group in standard care, no upper limit for use of fluid. IV fluid should be given based on surviving sepsis guidelines. In case of circulatory impairment, IV fluid should be given replace the observed or expected losses to correct the dehydration electrolyte dearrangement. IV fluid should be given as a maintenance to place in protocol with a recommended this. Management common to both groups. Isotonic crystolide is used. Albumin only allowed following the abdominal paracentesis. Commitment intervention for septic are detailed in trial protocol. Appropriate antibiotics, non-adrenaline as vasopressor, source control and RRT for routine indication. All other treatment including diuretic user discretion treating clinicians. Outcome. Primary outcome, death by day 90, restrictive in 42 versus standard 42. Adjusted absolute difference is 0.1, p square p value 0.96. Secondary outcome, no significant difference in number of serious adverse events, number of days alive without life support, number of days alive or out of hospital, no significant difference. In primary outcome also no difference, 42 versus 42.1 difference only. Serious adverse events, severe AKI, median number of days alive with or without life support, same as it is, and no significant difference in selected subgroup analysis also. Median volume of fluid administered in ml in restrictive group, first day 500, standard group 1333, IV fluid after 5 days 1450 and standard group 3000 around. No significant difference. Strength for this ICU trial. This is randomized multi-center trial involving the 31 ICU across the 8 European countries. Increase the external validity. Pre-published statistical analysis plan. Intention to treat analysis. Minimal loss to follow up. Balance baseline characteristics. Unwell patient cohort. Achieved a separation in fluid admission via trial protocol. Weaknesses. Unblinded trial. The most common infection source was GI. This may have necessitated large volume of replacement fluid if diarrhea or vomiting were prominent feature. Power for 7% reduction in mortality. Large volume of fluid given outside of the trial protocol. Nearly 3 liters of fluid given to each group in 24 hours prior to randomization. Total difference of fluid administered by days 5 was only 2 liters, with a difference only 800 ml in the cumulative day 5 fluid balance. This similarity between these groups may result in, if the standard care delivery in ICU already relatively restrictive, no maintenance fluid strategy. This potentially bias the result towards the null. Last number of protocol violation 21.5 in restrictive group versus 13 in standard group. In restrictive group, 64 of the violation were fluid bolus used without a criteria being made. Violation result in median 97 ml administered per day. In standard group, 100% of violation were no IV fluid being given only single day in ICU. This was 13% of patient with in a standard group. However, there was no difference in outcome when violation removed per protocol analysis. Author conclusion: in adult ICU patient with a septic shock, IV fluid restriction did not result in fewer deaths at a 90-day compared with the standard IV fluid therapy. May I suggest this study did not confirm my pre-existing biases in that restrictive fluid strategy was not shown to superior with respect of 90-day mortality to standard fluid management currently being practiced in European ICU. However, the 5-day community fluid balance in the standard group was not much greater than the restrictive group. Therefore, care is still required to ensure that every patient in ICU has a vigilant and considered fluid management strategy. This includes the de-escalation or evacuation phase of fluid therapy.